it's okay with you, it's probably best that we go sequentially through 3 different shorts. So let's go. There's no chairs up here.
Oh, I don't think it's up. We're fine with this.
Here.
There's
Oh,
chairs
yeah.
there, yeah. Oh, I didn't see that one over there.
So let's start with Quitters Inc. Observation.
Sorry, what did you say?
Quitters Inc. is the first short.
Oh,
Let's
gosh.
focus on that first. Let's go on.
So, okay, I'll just do an overview of things really quickly. I was very much not expecting the third sort of scenario to go the way that it did, this like sudden magical realism situation, given the lack of it in the first two. I thought that was like, interesting and slightly out of place.
It was, because the first 2 are adaptations of Stephen King short stories.
Right.
The third was actually written specifically for them.
Oh,
That's all.
okay. Interesting. So with Quitters Inc., I thought it was interesting when he starts hallucinating at that one party. And like, I was watching it last night with my husband, and my husband's like, oh, is that like some side effect of quitting smoking? And I was like, no, that's not a normal side effect, especially weeks after the fact. So that was more striking for some sort of psychosis. And it made me sort of like question his everything up until that point, whether or not it was real. Like he was, because I was saying like paranoia, for instance, the person following him the whole time, like what if that was actually all just paranoia, since now we're seeing hallucinations. So it made me question.
Let's talk about that. So with regard to nicotine withdrawal and the signs and symptoms we did see, and again, they're absent psychosis. I think one of the teaching points, especially for your self exam, is that nicotine withdrawal looks exactly like cannabis withdrawal. And that's noteworthy because cannabis withdrawal is new, right? It wasn't identified prior to 2013, at least not with the DSM. So now it will be appearing on shelf exams. So be mindful of it. And if you think to yourself, wait a minute, and I understand that Cat's Eye is not about cannabis, and therefore Quitters Inc. is not about cannabis withdrawal. But to the extent it is about nicotine withdrawal, we need to talk about this. You should identify in your shelf that the single best answer is cannabis withdrawal when the individual looks like they are drug nicotine. There really is one sign that is in stark contrast to nicotine withdrawal that you are likely to see in cannabis withdrawal, and therefore need to actively look for it in your clinical vignette. What is it? In cannabis withdrawal is weight loss, decreased appetite, which is the direct opposite. And by the way, not only is it the direct opposite in nicotine withdrawal, but it is actually part of the script.
Yeah, when he's like being weighed, and the guy says, all of my patients like gain so much weight, and I'll cut your wife's pinky off if you go above a certain weight. Because he's gained 8 pounds in 6 months, which is actually, I think, not too bad for most people going through nicotine withdrawal.
The weight gain in nicotine withdrawal can be significant. Yeah. So that's certainly something I want to get out of the way. Again, full disclosure, I do not believe Quitters Inc. is about cannabis or cannabis withdrawal, but the teaching point can still be made. All right, so now focusing
So I
on...
would also want to add, the first night that he's going without, and he's so irritable, and the wife is talking to him, he goes to the freezer to get ice cream. So it's like showing how he's like coping with it through eating as well.
And specifically carbohydrate weight, right, which I think is noteworthy.
Yeah.
Right? And I want to get into why now, and have that piggyback another observation you just made, and that is, where is this paranoia coming from? So, thoughts?
Well, you'd expect like some irritability, but paranoia, and especially potentially a paranoid delusion, would not be expected from a nicotine withdrawal.
Correct. So what's our differential? What are your thoughts?
I wonder if any of that was real, if the like saying they were going to come to his house and follow him was even real, or if that was all paranoid delusion, given his hallucinations later.
I agree.
I mean, it seems impractical for one. The amount that you have to pay to receive 24-hour service for 30 days would be exorbitant, so much more likely that this is all just a delusion.
And if we apply the step-by-step formulation that we discussed pertaining to Coraline here, we're not going to do it step by step. What condition are we likely talking about? That would account for his paranoia. Yeah, yeah. And is there then any part of schizophrenia that itself would not only explain the paranoia and other psychotic features, but also explain his difficulty with nicotine? And the answer is in the medical literature that nicotine acts as self-medicating psychotic symptoms. And that if he is getting treated, he's likely being underdosed. Of course, this may be new onset, or this might be chronic, and he might be on an atypical antipsychotic, because that is a known side effect. Now, we discussed this post-Coraline discussion with regard to antipsychotics, specifically haloperidol, and then in some instances, atypicals, second-generation agents, pertaining to their use in delirium, like Coraline. Let's also reflect on how we might consider using these agents pertaining to psychiatric conditions, such as schizophrenia. Number one, side effect profiles. For the typical or first generation agents, what are the side effects that you're concerned about here? Right. So EPS and NMS should be at the top of the list. They should be 1 and 1B. And then with regard to, I think, number 2, I'd like you to think of hyperprolactinemia, which is really an EPS. So they didn't include that, if, as long as you remember that it is an example of an EPS, right? Because the hypothalamic pituitary tract is extra outside of the pituitary. So it is an EPS. The other part of this is that I would like to then create another category that said other. So EPS, yes, NMS, yes, and then other would be number 3. The other side effects can be remembered by the acronym STOMAS, S-T-O-M-A-S. Try your best to give them an order.
Sedation?
Good. Why is there a change in vision?
I would say there's something like a yellowish tint to the...
That could be. The other big deal with vision and changes in vision is that it's an anticholinergic side effect, difficult to accommodate dry eyes. Right? So that would be the anticholinergic side effects, including, but not limited to blurred or double vision.
I think there are also some that have like a corneal and retinal.
Yeah, you are some. Yeah, chlorpromazine. Retinal pigment, I can't get the word. Pigmentopathy. I'm not sure that's correct. T, torsades. Alright. These are all agents that can prolong the QT interval and therefore serve as a risk factor for torsades. O, orthostatic hypotension. M, metabolic side effects. Weight gain, carbohydrate gain, diabetes, dyslipidemia. A, we said already, anticholinergic, and S is seizure. These can all lower the seizure threshold. If you're discussing the first generation or typical antipsychotics, EPS and NMS First of all, let's talk about M&S. And MS. We've got to think about this condition because it's life-threatening for all of the above. So let's not even worry about where this belongs in a hierarchy. So make sure we get that out of the way. So that's all important. EPS would be at the top of your list, and then other would be at the bottom of your list. When we flip over to the atypical or the second generation antipsychotics, the same exact side effect profile, albeit in reverse. Other comes first. EPS is relatively rare. EPS, the rule of fours. Number 1, 4 hours to 4 days. What side effect are we talking about here? Acute dystonia. Acute dystonic reactions can be local or general. Because of the rarity in which the treatment is applied by psychiatry, the large majority of shelf exam questions focus, pardon the pun, on the focal dystonias and what is the next best step. What is the treatment for focal dystonias? Always, right? But when that doesn't work, always lower the dose and discontinue.
Benadryl. Or Beckenridge.
Second line. And first line for the general dystonias.
Benztropine.
First line for the general dystonias.
Baclofen? Like a muscle relaxer?
General dystonias. Botox injection. And because of that reaction everybody just had collectively, that's why question writers include that on shelf exams. Botox. 4 days to 4 weeks. Akathisia is the most common side effect, if ever asked. It is a subjective sense of motor restlessness. The individual will often tell us that they have to shift their weight when they stand or feel compelled to walk or pace. Akathisia. Treatment of choice. First line. Benzos, here's the hint, are indicated in individuals suffering from akathisia with coexisting asthma. Beta blocker, first line agents, beta blockers. The other thing about akathisia, most common beta blockers, is that there is a relationship with iron deficiency. So if your patient demonstrates anything that might suggest anemia, always get iron studies. 4 weeks to 4 months. That's 4 months to 4 years. Good. Parkinsonism as well as postural tremor. Right, so just think of the tremor disorders. The first is postural tremor. That's tremor against gravity, arms extended, fingers spread, postural tremor. The tremor for Parkinson's disease or neuroleptic-induced Parkinsonism is the pill rolling tremor. So the true tremor syndromes. In those situations, again, always lower the medication, switch the medication. But if the medication is effective and it's kept the patient out of the hospital for the first time in their life, then a combination of Benadryl and Cogentin. And then finally, tardive dyskinesia. 4 months to 4 years. Tardive dyskinesia works in or with a reverse mechanism. All these medications lower CNS dopamine to resolve psychotic symptoms, so the hallucinations, the delusions may and will improve. But unfortunately, dopamine ubiquitously gets lowered in other brain regions as well, causing these extrapyramidal side effects, or EPS. So there's no such thing as localized dopamine inhibition. On the other hand, with chronically low dopamine levels, the postsynaptic receptors and gene expression multiply. And as a result, you have, through that reverse mechanism, tardive dyskinesia, which is an involuntary movement disorder that if you don't catch early, is likely to become irreversible. Involuntary movement. TD. If you increase the medication, increase the dose, the TD will resolve, but it'll be transient. It'll come back and perhaps it'll come back worse, albeit now at an increased dose. Increase it again, it will resolve again, transiently. And now you're at a double dose. So upon first recognition, don't even play that game. Switch the medication, the single med that right now the APA suggests and recommends you switch to is Clozaril. Clozaril has such a low incidence, and there is evidence in the medical literature that it reverses the effects of TD. So, if asked, switch over to Clozaril. Now, there's a newer med as well that you could add on for TD. I'm liking on the name, and it's new enough where it's not going to show up on the shelf again. Any questions with regard to EPS? NMS, neuroleptic malignant syndrome. Again, this is a state that is a medical emergency due to the lowering of CNS dopamine. In this case, you can give a dopamine, well, first of all, of course, you're going to discontinue the offending agent. The second thing to do is consider adding a dopamine agonist to replenish CNS dopamine, even if that makes your patient psychotic again. That is the worst of two evils here. Supportive care, which is usually at the level of the intensive care unit. Monitor labs closely, including albumates or CPK, electrolytes. Supportive care also focuses on vital signs, including fever. And then for the muscle rigidity, consider baclofen or other muscle relaxants, including benzodiazepines. Again, that's usually ICU care. That's NMS. NMS looks an awful lot like the serotonin syndrome because both hallmark acute mental status change, otherwise known as delirium, below core line yet again. Autonomic instability. But there is no, or I should say muscle rigidity, while defining of NMS is rare, relatively rare with serotonin syndrome. Also in NMS, individuals usually have areflexia. So they have loss of feature and reflex. The opposite is true for serotonin syndrome. So while somebody with the serotonin syndrome is likely to be delirious with autonomic instability, fluctuations in blood pressure and pulse, hyperreflexia is defined, and absence of muscular rigidity. They also, unlike NMS, are likely to provide upper motor neuron signs. So myoclonus, along with the hyperreflexia. Questions about antipsychotics?
Just tell me what I need to know.
No, absolutely on cue. All right, back to our movie. Again, with the carbohydrate free, might that be evidence that our main character, Twitter Zink, is actually on an antipsychotic, for which he is not getting full relief and therefore continues to self-medicate with nicotine, right? Acetylcholine is implicated along with the dopamine hypothesis with regard to the biological etiology of schizophrenia and the anticholinergic effect, the anti-nicotine, the cholinergic agonist effect. That is the nicotinic receptor agonism of nicotine could be a form of self-medication for psychotic symptoms. So it's not acetylcholine, it's not anticholinergic, it's a choline agonist. It's acetylcholine agonist. Any other thoughts about Twitter Zink? What type of therapy is employed by this organization when you flash back to Psychology 101 and learning theory.
Conditioning.
Conditioning, right? Operant or is it last one? Operant conditioning. There are two forms of operant conditioning, reinforcement and punishment. Which one is taking place here and why? Punishment, why? Because it looks
Negative.
Huh?
They receive something they don't like to negatively reinforce the behavior.
It's like a positive punishment because you're adding something.
That's my next question. Hold on to that thought. Thank you. Bottom line here, and the question the test taker must always ask himself, is the behavior being reduced or extinguished or increased?
Reduced. Reduced.
Reduced. So it has to be punishment then. That's the bottom line. If it were the opposite, if the behavior is strengthened or increased, then it must be reinforcement. As soon as you get into column A or B, then you have to ask yourself the question, what's the prefix? Positive or negative? How do we determine that?
If you are giving something to the person, you're taking something away. And so in this case, they were giving bad things to him, so it's so positive.
So the prefix of positive is going to be added, so this is a form of positive punishment. Right? The addition of a noxious stimulus, addition, positive, to reduce behaviors, specifically smoking behavior, punishment, positive punishment. So build that 2x2 rubric in your head, mental image, and you'll never get an exam question at all. Any last thoughts with regard to quitter safety? All right, the ledge. We got.
There's like references to somebody being like on drugs, like the washed up tennis player.
What drug is that? What drug?
I think like cocaine, but they even tried to plant heroin in his car.
All right. So if the writer-producer, maybe even Stephen King himself, contacted you and said, you know, we do want the clinical index of suspicion to be a little high here, so to confuse the audience, is he actually using heroin or not? Give me some signs of heroin or opioid intoxication that this character would have demonstrated. So that's number one, is pupillary constriction. That's number one. I didn't get it close, I did not get it close enough to look at it once. I couldn't do it. So.
You might expect to see like some sedation, but he's not displaying any sedation that you would see with like an opioid.
Right, and that can include coma or
Yeah.
some other form of mental status change,
Mhm.
right? Respiratory depression. Per the DSM, the acronym of all things, believe it or not, is CAT. So the pupillary constriction isn't necessary. When everybody thinks of that, you have to have that. And then you need only one of the following three: C, coma, or other form of mental status change. A is attention, deficit in attention, and T is talk, so slur of speech. CAT. I didn't see anything here. So this guy's being framed. By the way, if towards the end of this, let's say after he puts the gangster on the ledge, he's walking away, what might Stephen King have had he considered with regard to opiate withdrawal, heroin withdrawal? So the acronym here is TGI Fridays.
GI, like stomach pain, diarrhea.
Proclamation.
I mean, he does cry, but.
Well, dysphoria is there too. TGI Fridays, T3, need three at the bottom. GI, we already got, right? Nausea, vomiting, diarrhea. Fever, rhinorrhea or lacrimation. Insomnia, dysphoria, arthralgia, yawning, sympathetic symptoms. Sweating, piloerection, increased BP, increased pulse. Sympathetic. Anyone, right? TGI Fridays. Not really much here. What's going on in the gangster? Oh, by the way, before we get to him, let's stay on Robert Hage's character for a second. let's say we're wrong. Let's say that after he leaves the scene, he demonstrates at least 3 of the symptoms of TGI Fridays. And he presents to our ER as admitted, and you're consulted. We want to do. By the way, I think this is directly related to one of the consults that was called in when you've seen.
I saw opiate withdrawal patient.
There we go, right? So how do we treat opiate withdrawal?
Suboxone.
Right, so that's an option here, right? So number 1 is an option called substitution therapy. The physician substitutes a medication for the drug of choice that has the same mechanism of action. So for heroin or other related opioids, we substitute a medication with that same mechanism of action. So options include methadone, which is a pure mu opioid agonist, or Suboxone, which is a partial agonist. Well, buprenorphine is a partial agonist. Suboxone is a partial agonist antagonist, right? It also includes naloxone. So that's an option, substitution therapy. There is Part B that we consider, which is just symptomatic relief. For every one of TGI Fridays, well, not the T, but every one of the GI Fridays, we give symptomatic relief. So an anti-diarrheal, an anti-nausea med, etc. And then, of course, option C is to do both. Do both. And that's the way a site consult team usually medically manages opioid withdrawal. Substitution therapy and or symptomatic relief. Patient goes through their opioid withdrawal successfully and is now ready for hospital discharge. They follow up in an outpatient clinic that you are staffing. You identify that opioid use disorder is an Axis 1 psychopathology. Now they are recovering, so there's sobriety. And you offer a biopsychosocial treatment plan for this particular patient. That would include what? Now, psychosocial would be attending NA, 90 meetings, 90 days. Biologically, it's the reason why we're seeing you as a prescriber, biologically, what are some considerations here?
You have to keep following up with them because the risk of relapse is high.
I would absolutely suggest that as a practicing psychiatrist and prescriber, you screen for, diagnose, and manage any co-occurring psychiatric conditions. Of course, if they get misdiagnosed or missed, the likelihood of relapse is significantly higher than if you actually discovered and treated them appropriately. And all of the above would require frequent follow-up, probably on a monthly basis. Nothing is found, hypothetically, nothing is found. I want to keep this a clean case with regard to the medical management of opioid use disorder.
Give like naltrexone.
Yeah. So in situations like this, you have to have a discussion with your patient as to what their ideology is. Are they receptive to the disease model? That they have a disease, and that disease should be approached with abstinence and sobriety. So yes and A, but then medications that are on the table would be naloxone, naltrexone, with regard to reducing cravings for opioids. On the other hand, if they are not receptive to the disease model, but instead a harm reduction model, that says that they can be continued to remain dependent on the drug, albeit prescribed by a licensed physician. So there, naloxone is like, or naltrexone is likely off the table, and instead, Suboxone is something that you can consider. Suboxone is the office-based management through a harm reduction approach of opioid use disorder.
Between like Suboxone and methadone, methadone is the one where they have to go every day to a treatment facility to pick it up in the morning.
Exactly right.
Yeah.
If the patient says, I have an allergy to Suboxone, but I still want a harm reduction approach to my addiction, then methadone is another option. Unfortunately, you can't prescribe it. They would need to go to a sanctioned methadone maintenance clinic. Daily basis, they're open Monday through Friday. These are clinics that are, so don't think that you automatically get approved because you want to prescribe methadone to help your patient. Monday through Friday, they get their dose, they take it. On Friday, they get 2 take-home doses, one of course on Saturday, the other one on Sunday, return back to the clinic first thing in the morning on Monday, and they can be maintained on methadone indefinitely. The likelihood of remaining sober is about 30%, which is equitable to more traditional programs, where they separate, that is, methadone maintenance separates from the traditional disease model, is that there's a decrease in criminality, there's a decrease in HIV transmission. So, that is an option. Although, we would need to refer the patient to the clinic. What else is going on in the ledge?
Personality-wise, I would say there's some, and maybe this would be expected of a top gangster type of guy, but quite a bit of narcissism with probable, narcissistic personality disorder.
There's a lot there.
Yeah.
So that's like social too.
Yeah.
By making the guy go on the ledge and still do everything he could to try to make him fall.
Yeah.
That is very antisocial to me.
Yeah. He was toying with him.
It did seem like he took special delight in this. Now again, so as not to pathologize behavior, this may have been an overreaction and a legal one at that, to the discovery that his wife is cheating on him and he's taking it out on her lover.
But I found it interesting because when you see him in the beginning, he has this sort of brief little whispered conversation with his driver who's going to be involved in getting the guy. And then he just switches right over to talking about this bet with the cat naked, and he is pulling for the cat to be safe. So it's interesting. It doesn't seem like he's in this, temporary insanity from his wife, finding out his wife's cheating on him. It's almost like he only really cared about the fact that his wife was cheating on him in the context of sort of like an insult to him and his pride. It doesn't even really seem like he had much of an emotional stake in that setup.
But at the same time, at that point, he had already killed the wife, I believe, right? Because he shows her head.
Yeah, but it doesn't really seem to be super, he doesn't seem devastated. He doesn't seem sad. He doesn't seem hurt. He just seems angry that somebody would challenge him in a way.
A couple of thoughts with that, with regard to the scene and behavior that you identified. One, if you truly believe there's empathy there for the cat, the question really comes into context. What is he like prior to the discovery that his wife was cheating? Because if you get into the, and you're not going to ask him because he might actually be a little bit of a liar. But if you could establish that he was quote unquote perfectly normal, then there's something much more going on in the personality disorder. Right? Personality disorders are stable over time. And if the behavior that we're observing is incident to the discovery that his wife is unfaithful, there's something going on. Right? Again, I think this comes to the attention of the police, but not a psychiatrist. The other part of it too, with regard, and again, I think the empathy for the cat is the red flag here. Having said that, though, there's another reason why he may appear empathetic to the cat, and that is he's just playing the odds. He really does think the cat's going to make it. And the only reason why he's rooting for it to be safe is not because he wants the cat to be safe, it's because he wants to win the money. And that takes us to the next part of the conversation. That's a condition called gambling disorder.
But his behavior immediately after that, where he picks up the cat and he's holding it and says, "Oh, I'll take it home and get you food or whatever," he actually does seem to show some affection towards the cat.
And you know that the opposite is likely true with regard to the pre-existing condition of conduct disorder, which includes cruelty to
Yeah,
animals,
yeah.
required for the diagnosis of antisocial personality. So this is not a straightforward case of antisocial personality disorder, despite recognition that he does have that cardinal trait of a complete disregard for violation of others' rights.
Yeah.
That complete disregard, again, might fall under the authority of police, and perhaps not psychiatry, because it's a very complicated case.
That's what made me think of like the narcissism a little bit more, because it seemed like he only had some of this disregard when somebody like challenged his authority or his pride. But with the cat, he wasn't doing that, so he felt no threat and could be nice.
The existence of gambling disorder in this particular segment reminds us that with the new revision of the DSM, the chapter of substance use disorders was revised and was renamed the addictive disorders, for which there are two parts. There are substance-related disorders and there are non-substance-related disorders within the new addictive disorders chapter. Substance-related disorders include nicotine, tobacco, so that's the first segment, that's Putters Inc. As part of this segment, heroin, opioids. That second part, the non-substance-related disorders, includes 1.5 disorders. One is gambling disorder, which is what this segment is really about. Okay? If you look at gambling disorder previous to 2013 in terms of its DSM definition, the actual criteria really matched up very well with other substances, alcohol, cocaine, etc. So it was only a matter of time until that condition was moved over from the impulse control disorder chapter to the addiction disorder chapter, because the signs and symptoms really did look like an addiction. They always have. The other condition here is one that is not in the text of the DSM, but in an appendix in the back. So that means it's going to be moved into the text in the next provision. What is the other non-substance related addictive disorder that the APA is getting ready and prepared? More information, they're doing more research, but it's going to be moved into the text, likely with the next DSM revision. Anybody guess?
Video game disorder? Video game obsession?
Internet gaming disorder.
Oh.
That's the next one. So there's going to be two examples pretty soon. Internet gaming disorder, not really part of this movie. Any other observations with regard to the ledge? All right, general. The third and final chapter of Cat's Eye. Thoughts?
I thought the mom's character was interesting. I don't know if I would say it ever reached anything that seemed to warrant like a clinical like consideration or diagnosis, but like the mom did seem to have like some anger issues, like how quickly she was upset at General for like even the idea that he would hurt the bird. And how like sort of the dynamic between, like she was definitely the bad cop of the parents. And I noticed on their refrigerator, there was, you know how like families would have like little things that the kids have like written up and like drawn or whatever on the refrigerator. And I noticed on the refrigerator, there was one of those where the girl had written something like, "I am upset when my mom spanks me," which was just like oddly dark to have up on your refrigerator and like kind of weird. And it just sort of pointed out like sort of the mom's anger.
So take it from the context of what you probably heard me say before. Anytime a patient presents you with a chief complaint, I'd like you to first consider that it's initially approach each case that it is normal behavior until proven otherwise. And that includes when it's about 2 seconds before it's proven otherwise. Just train your brain to think like that and give your patient the benefit of the doubt. even though you know it's not normal, right? So it just gets you into a mode of thinking that I think is being clinically aware. Along those lines, there's a couple things to consider here with regard to this observation. Number one, that this is normal behavior. And if it is, it likely gives a peek into the dynamic of the family, of how impulsive or how mood labile this character is. So that's a consideration here. And again, that would be from the approach of this being normal.
Yeah, like when they're sitting there having breakfast and the dad sort of like mimics the grandmother's accent, and she gets so upset that he did an accent for her mom that she says she can't even eat and goes and like throws away her breakfast. That did seem to be a bit labile.
Yeah, I don't know, I felt like all of the things she was doing was pretty normal, just because, I don't know, people get frustrated at things, and like, I can imagine that, because it seemed like it was something that the husband had done before too, and it's also her mother, so I just kind of put that in the realm of, that's it, okay, just to get frustrated about it. And I also felt that way about when she said no to having the cat, and when she saw the cat, like, break the bird, like, sometimes one of the parents just does have to play bad cop, and that's obviously the role she has, and I felt like that was totally fine to do, because you can't just, like, let everyone just run around and do everything.
I had the same thought. She was worried about the birds, so, and I can relate to it because my dad has a lot of birds, and then one day I show up at home with a cat. So he had the same concerns, like, he's the cat, going to get my birds. And he didn't want the cat at first, but not with that friends, but I could understand where she was coming from with,
Yeah.
that regard.
I just felt like sort of her affect and everything else, like when she was trying to capture the cat, she just seemed like so angry at the time, and like she took the cat to a kill shelter so that it would, and it lingered on the smokestack before, like when she's pulling into the parking spot, and the camera lingered on the smoke coming out of the top, as if like she knew she was taking it to be put down, which seemed maybe excessive. I don't know.
I also think that the fact that her mother's accent was brought up kind of just brings up the interesting point of having to take the cultural context into consideration before like apologizing the behavior.
Yeah, absolutely. Again, the clinical consideration here is, are we looking at something that would be in the context of a normal behavior versus a true psychopathology, and the clinician would start at point A and then arrive at point B only when presented with that evidence. And I think that point B would begin with a discussion of an impulse control disorder. But again, there's disorder impulse control in other illnesses too, mania, personality disorders, etc. So very broad differential there, if we ended up going there. The one thing I will say, which again gets to more of the context of this being normal, and therefore a little bit of a peek into the family dynamic, is that this dad, not only does he take on that role to the top, but he also seems to be, to me, emotionally disengaged. I don't really see him as a supportive spouse. I don't see him setting himself up as there being a family unit, a dyad from us with regard to being a parent. And that's dangerous when the parents are not viewed by the child as a singular entity. When the child understands that they can go to dad for one thing and mom for another, that's a potential for disaster when it comes to parenting. And we see this in The Shining too. And that case study doesn't turn out well either. So again, just a consideration. Other thoughts here?
I want to comment on the troll, with the little girl sleeping at night. It's interesting that the parents see the evidence of it and they still kind of don't, you know, like when the troll goes into the van and stuff, and they're kind of like, not really sure what's going on. So I was thinking that maybe she has some kind of sleep disorder, like night terrors or something like that, and that maybe she thinks the cat is protecting her from this troll that she's imagining, but in reality it's just kind of common for anxieties and usually like being used more as like a emotional support animal type of situation.
So undiagnosed sleep pathology.
Yeah.
It's fair. Again, the major scenes here, when we look at this behavior in the context of the child, is again, focused on the veteran. So sleep pathology probably would be higher differential. One of the concerns I have here, and this is taking a little bit of creative liberty, I've looked over a pretty extensive list of fays, trolls included. None of them steal rabbits. I mean, fays, the fay universe, have extensive characteristics, very frequently malevolent, some beneficent, but none of them include stealing breath. So, what's going on here?
I've actually heard that that's associated with cats. So I thought that was a weird, thing.
So, and I'm not saying that's true. I'm saying that there is folklore that exists that cats do that. I'm not saying cats steal breath. I'm saying that folklore states that cats steal breath.
Isn't that like, so I've heard that, so like that folklore would have arisen because like cats will often come and sit on like the chest of their like loved caretaker in the evening, or even like on their face. And you know, that would be well, the cat did it at the very end. He came and he sat on her chest, and then he came really close, and then he just like kissed her face, like with like licks or whatever.
Hey, really?
Yeah, so that's kind of the question.
Where else have we seen this? Yeah. Yeah, another family dynamic where mom is a bad mom. I mean,
Oh, I thought you did the breath.
a real bad. Dad is
Yeah.
out of it, and you've got a cat that is sitting on Coraline's chest, and there's a scene where he actually pinches her nose. He's stopping her breathing. So there's a little bit of a parallel here.
I also thought it was interesting when at the end, like the mom's immediate reaction was like, don't tell anybody, we won't tell anybody about this, and like to the daughter, like, don't tell anyone about this, like at school. And this is like definitely a stretch, but it kind of just like reminded me of like abuse in the home, especially if it's like from a relative, and you could maybe think of like the troll as some like male relative that she might would have who would like be in her home, and that when it is a family member committing abuse, other members of the family can say like, oh, we don't need to tell, we can solve this at home between us. We don't need to tell anybody.
I agree. Again, reframe this on how things might sound if this family presented to you in clinical practice. At some point, if you're around with Dr. Ilaria, she is likely to ask the parents to momentarily leave the room. And if during that time, this little girl tells you that at night a monster comes in my room and he tries to attack me in bed, there's no way any of my medical students would think, oh, little girl, you have a troll visiting you through a magic door. Right? No medical student's going to think that was not a proper wood. Right? I mean, your mind's going to go someplace else. So, with all due respect to the supernatural aspect of this film, at some point, we do need to look at this through the lens of a psychiatrist. And abuse has to be on the table here. Oh, by the way, we've seen this before. We've seen this before with regard to the setting being a little girl's room, and there being abuse in the home, a home that includes a cat. I mean, there's an amazing parallel between this film and the film we discussed at 11 o'clock. Other thoughts?
I agree with the abuse thing. I thought that was a weird thing to bring up too.
Yeah.
Was that?
Just the fact that the mom was like, don't say this to anyone at school. And when I saw it, I feel like I look at a lot of things at face value when I'm watching movies. But when I originally saw it, I just thought she kind of like didn't want her daughter to be embarrassed if she just told the story at school, and then people would think that, like, I thought that she would think that classmates are making fun of her. That's how I saw the scene.
I thought about it, but I thought in the sense of the mom not wanting all the people and all the parents to find out that this
And again, when there's this level of ambiguity, and that's the wonderment of film, is that there should be gray. Hopefully, the writer-director is not spoon-feeding us, because that would ruin everything. And you heard, and those of you who attended last night, you heard Phil say this multiple times. Abstract discussion thrive. And if this person, this little girl, were to see what she said at school, and if there was a teacher, principal, or even a counselor, the idea wouldn't be, well, if you think you're getting visited by a troll little girl, don't say it because you're going to get bullied, because a lot of it's true. The counselor's got to think there's something going on at home. It's a home visit, that's it.
Yeah, especially given the nature of, like you said, it's in her bed, it's at night, it's only ever at night and in her bed, that's.
That would be cool, it just popped in my head, is that somehow, if we watch this again, remember in between segments, the cat's running through the streets and there's a car accident that results. How cool would it be if that was how Coraline Tucker? In terms of
Bridging universes.
Yeah. Stacked universe. Any final thoughts about Cat's Eye?
I have a question. So you know how like the cat keeps seeing a girl? I was wondering, like, it happened so quickly I couldn't quite tell if that was Drew Barrymore as well. Like in the commercial and in the mannequin, it looked like Drew Barrymore, but it just was so quick. I was like, was that supposed to be her in each of these scenes? Like, I couldn't quite understand that one. So I'm just curious your thoughts. It looks like Drew Barrymore.
She was asking help throughout the movie, and then at the end, the cat goes through exactly.
Yeah.
Because if it wasn't her, I was like, what was the?
Yeah, exactly. Yeah.
Yeah. No, I mean,
I tried to look in the credits, but it just said "Our Girl" as Drew Barrymore, and it didn't specify. So.
I gotta double check that. And interesting, one more, I think, teaching point here then. I've made multiple allusions with regard to this film and The Shining, right? And this final observation is yet another allusion to Stephen King's, or I should say, Kubrick's The Shining. And that is the idea of the doppelganger. Is it or isn't it one of the characters that we're seeing? Because this exists in The Shining. Anybody familiar with The Shining? Okay, so you know there's significant controversy with regard to the final scene and the picture on that wall. Because it shows the July 4th ball from the 1920s. And right in the middle is Jack Nicholson. And what the heck does that mean? If you have a weekend free, go down that rabbit hole, because there's more than one conspiracy theory about what in the world that can mean.
I feel like Stephen King's also interested in that, like with The Outsider. There's that doppelganger situation.
Yep. There is a psychiatric condition called the duplicative paramnesia, which is a delusion, specifically a delusional belief that you or your immediate environment is replicated somewhere else. Right? And I just wonder if that's an illusion here, or a demonstration, illustration in Cat's Eye as well. Again, connecting to Stephen King multiverse.
Which they did a lot in this movie. There's so many, like when they were when the husband and wife was laying in bed at night, and one of them was reading like Pet Sematary. There's so many like little references to other Stephen King.
So what I would submit is that they did it more frequently than they even realized.
Yeah, like Cujo in the beginning running around,
Christine.
and Christine on the bumper sticker.
All intended and all a conscious effort. I'm wondering if Stephen King had some subconscious effort here as well.
Probably.
With both allusions made to The Shining, including the three that we came up with in discussing Cat's Eye, especially General, which is the third segment. I will leave it there. What time is it really at? I take a brief break, stretch, 5-10 minutes, come back. If you want to text the group, we'll be back in 10 minutes with our case presentations. I'll grab my computer for you guys.
Where's the